So as you know, the presentation's aiming to tackle the screening disparities amongst the LGBTQ community. We've just done the other slide by introducing ourselves, so we can go straight on to the next one after that. Which is Hannah.
Yeah, so our objectives for today is to raise awareness for the low percentage of cancer screenings in the LGBTQ plus community. And we want to educate you on the barriers and to healthcare and the facts and statistics that you may not have known before this session. And our last objective is to inspire you to raise awareness in and amongst the institution.
So before we can talk about cervical, breast and prostate cancers, I think it's useful to discuss some of the barriers in the health services. So when we was researching, putting the presentation together, one of the main bullet points I thought was worth including, it's getting better narrative. And so the number one reason for low screening is that we kind of base everything off statistics and facts, but we don't really look at beyond them statistics. And all of statistics may increase on people attending the screening. We don't really think about anything beyond it. We just think it's getting better, but we don't focus on the other percentage who are not attending, which leads on to the next bullet point that shows that studies show massive concern for how the LGBT community have fears to come out in a cancer treatment setting. And one of our aims was on this presentation to kind of discuss why that reason may be. And like I said before, when we was doing the research, it was all just based off statistics and facts, and it all just follows a quantitative approach kind of, and we don't really think about why the reasons are. We just look at the percentages and then we kind of just read it and then ignore it, whereas I think we should think about why the statistics are this way and why we feel like this, and which will lead on to the later slides, and plus a bit of a Q&A with Jane might help us get to the reason as to why it's always statistical and never one-to-one on that, which I'll lead on to knocking stuff over, Rosa.
Yeah, just to draw attention though to these, although we're saying like we can't just have statistics, just to draw attention to them, that 14% of LGBT people, and that's including 37% of trans people, which is a massive percentage, have avoided health screenings due to fear of discrimination, which is just shows what a problem it is. And like this is affecting a large number of people and it can't just be ignored. And again, 16% of respondents have had a negative experience based on their sexual orientation, and then 38 based on their gender identity. And this is obviously just to say like this is a real problem that needs to be addressed and looked at. Yeah, and then I think we're moving on now to talk about cervical screening with Hannah.
Yeah, so cervical cancer is a type of cancer that takes place in the cells of the cervix. So essentially it's in the lower part of the uterus that connects to the vagina. So many strains of the HPV, which is a sexually transmitted infection, plays a role in causing most cervical cancers. And considering who it will affect, it can affect straight women or women in the LGBTQ plus community, such as lesbian and bi, non-binary and trans men. So of course, if you fall into any of these categories, you can be at risk of cancer and of this cervical cancer, and you will have every right to access a screening, so which we will move on to talk about. So when looking at the statistics and the facts in relation to the LGBTQ plus community, it is quite concerning, and a lot of them has to do with the barriers. So firstly, you can see on the slide that 15% of lesbian and bisexual women over the age of 25 have never had a cervical screening, compared to 7% of women over the age of 25 in general. So of course, a lot of factors go into this, especially in regards to the barriers in health care services, where 37% of lesbian and bisexual women were told that they did not require a test because of their sexual orientation. So for context, although HPV is certainly one of the main causes of cervical cancer, the way that people in the community are treated is unacceptable, and lesbian or bi women are still very likely to be at risk from this cancer. So lastly, 14% of women as part of the LGBTQ community have been actively refused from taking up a cervical cancer screening by a healthcare professional due to their sexual orientation. So this is definitely discrimination, and this can prevent people from getting the help that they need. And it also stops people at potential risk from preventing cancer. Preventing cancer due to their sexual orientation. And to finish the point off, if anyone knows anyone in the community and you're being refused to get a screening, hopefully this will never happen, but of course if it does, it's definitely your right, and you should consult a different healthcare professional's opinion to see to get a screening.
Right, so I'm just going to speak a bit about breast cancer and then screening. So, I mean, the first thing is often thought of as a women's disease, breast cancer, but it can affect absolutely anyone. Everyone has breast tissue, and it can affect all genders, although most common in cisgender women, and then trans men and non-binary people who assigned female at birth who still have a breast tissue. There is also, like, it should be noted that there's increasing studies to talk about the effects of hormones that can have on trans women who are assigned male at birth, and the effect that taking these hormones might increase their chances of breast cancer. But again, just to speak to it, as often as a trend with this type of, with the LGBT community and medical research, there's just not enough research there to like have to understand the evidence properly. There's not been that many studies, and there's almost no studies on taking masculine hormones and effects that might have. So yeah, that's just another inequality that we can draw attention to. But anyone registered as female with their GP should be invited for a mammogram every 3 years from 50, which is obviously great, and everyone should take this opportunity. However, the problems are that it can make assumptions about what body parts people have and how they identify, which is why some people may put it off going for screenings, and then therefore we can't catch the cancers early. Treatment can be difficult and a lot harder just on everyone. So you don't have to, if you don't want to say anything about your gender or sexuality at a screening, you absolutely do not need to. But at the same time, if you do disclose, you shouldn't be judged for this. There should be no, like, you should be able to be who you are completely comfortably. And yes, sorry, I've lost my track of where I was reading. But yeah, basically, that was it. Sorry, you can move on now, Laura.
Yeah. Just the next slide. Sorry, Hannah.
Sorry, the slide's stuck on. Oh, there you go.
So what I'll do is I'll just read the facts that we see on the internet as they are, and then I'll just talk a bit about these facts and statistics on a deeper level. So what we can see is that in the UK, prostate cancer is the most common cancer in men. As a result, 1 in 8 men at some point of their lives will get prostate cancer. And although prostate cancer is often described as a male cancer, anyone born with a prostate can develop prostate cancer. So this can be trans people assigned male at birth, and male assigned non-binary people can get prostate cancer. And 90% of gay and bisexual men in the UK have never talked with a healthcare professional about prostate cancer. And I know with prostate cancer, it's a harder one to tackle, because I know that if you're a heterosexual man, that you have difficulty speaking about stuff like this as well. So I think it is a deeper level for men in general, not just trans, homosexual and heterosexual. On the next slide, we can see that gay and bisexual men have no increased risk of prostate cancer as compared to straight men. And the risk of prostate cancer isn't increased by oral or anal sex. So when we look at like the stats and statistics we've all said, from myself, Rosa and Hannah, what we can see is on the NHS website, it states how existing evidence shows that health outcomes are generally worse for LGBT people, and their specific needs aren't taken into account. There is something called an LGBT action plan, which runs off surveys and quantitative debates, which just shows that these stats shouldn't, we aim to show decreased stats and increased equality aided in the sector. And when we think about it, if the issue is LGBT people feeling prejudiced towards, shouldn't we stop these sort of like surveys and focus on going into practices and health and observing how health professionals are doing what they're doing wrong to make the patients feel this way? And shouldn't it be like part of a mandatory practice for inclusion and equality for any type of person accessing healthcare practices? And a last point I'd like to finish with that is that LGBT people would rather risk their lives and get cancer than just go to the screenings just because they felt prejudiced towards, which is, to me, it's completely mind-blowing really that somebody would feel so scared to go and get a screening based on how they're going to get judged based off sexual orientation. So I'll pass it on to Rosa, sorry.
Yeah, and just kind of to lead on from what Laura is saying about what everyone has the right to, should have the right to fair treatment and should have no fears going into a medical practice that they're going to face discrimination. It's like actually mind-blowing that this even has to be discussed, but it does, it really needs to be. And that should go into as well with trans and non-binary people, the right to request what pronouns you refer to, even if they're different from what you may be registered as on the NHS, that you can still change how you're referred to. You can speak to your GP, your preferred name can be changed. And I think it's important that these things are known, and also that staff are educated on how to deal with these issues. And that basically these should be respected at all times. Also, from a lot of research, found that like a lot of the LGBT community didn't feel comfortable coming out in support groups. So I think it's really important that there is these access to support groups and for LGBT people, or that understand this, and then you can have proper support and feel comfortable you are like and free from judgment at a time when it's most important, when you're going through something like cancer, which can be really hard. The last thing you need is to have another worry on top of you about your own identity and how people perceive you. So yeah, that's more just to say about how important this is. And
then so when we was discussing as a group ways that MMU can help support students or anyone part of the community to improve screening uptake amongst it, suggestions that we had could be newsletters. I know that each week on my email I get newsletters for mental health, and at the moment very much so the COVID and stuff, but you never see anything for the LGBT community, and you don't even see anything for cancer screening. Like before doing this intern, I had no idea of what age you go for certain screenings. More faculty awareness such as this. I mean, although we've got a small turnout today, it's better than none, and drop-in sessions proved to be most effective, as well as social medias. Last week, myself, Rosa, Hannah, and one of the interns had done an Instagram takeover on the student union page, just raising awareness and hopefully educating people who was viewing the stories. And somebody on the intern had said on their presentation that on average a person speaks 16,000 words a day. So if we can use some of the words to raise awareness, ask your colleague if they've been to the screening, and maybe during lessons, if you could just use 5 minutes of your lesson at the end to maybe educate your students and sort of raise awareness, this could be a good idea. And then another idea is that we view cancer as this taboo subject, and like it seems personal, but I think if we talked about it more and don't be afraid to get a conversation started, then I think equality would be achieved amongst medical centres. And if you know someone a part of the LGBT community who's going to a screening appointment, reassure them and tell them not to be afraid of who they are, because as we all know, cancer has no prejudice, so you should just go to it regardless of who's in that medical centre. And
sorry, can I just add on? I was just going to say that, like, just for what you were saying about reducing fear and like increasing awareness. Again, I didn't know as much about the cancer screens before I started this internship, but I think if people know from a younger age, like obviously I'm 21, we're all around the same age, it's less scary because it's not as daunting when you do then receive that letter that you've got to go for a screening or stuff like this. And if education, just having the conversation going, does just so much help to increase awareness. So yeah, just to add that on.
So the next point, if we could nick a bit of Jane's perspective, so we just come up with some questions we'd like to ask Jane. So, well, first of all, we'd like to thank you for helping us get awareness out and get people attending to the session, Jane. But obviously, I had you in second year, and I remember on the first lesson on my first day with you, you talked about a bit about what you did before you was a lecturer at MMU, and you talked about working in healthcare research and stuff. So one of my questions for you is what research did you do related to this matter?
Oh yeah, well thanks for asking me to say something. If I had a bit, and then because I'm sure people have got questions, it'd be nice to have a chat, and it's nice to have a smallish group actually so we can talk about it. I just did, it was about 20 years ago actually I started doing it. I saw a job basically, a lesbian and bisexual women's health need assessment job that Bolton and Wigan Community Healthcare Trust had. They had allocated some money. They'd kind of basically looked at their communities and thought about the kind of healthcare provision they're providing and thought, actually, we don't know what lesbian and bisexual women need. We don't know if there's any issues, we don't know if there's any differences. And I think I started off, even as a lesbian, thinking, oh, I don't really know. I don't know what, you know, what might these be? And it was so interesting. So it was meant to be a 6-month project, and I think I was there for about 3 years in the end.
Wow.
And we did lots of community development work. And I think you're so right that you need the clinical information and the technical information. And I've been talking this week with other people about, although we now have sex and relationships education apparently more firmly in the school curricula, it's still not properly supported. You know, teachers still don't get trained to deliver it. It's a really complicated subject to deliver. And for me, education is so important. So I loved what you were saying about, for yourselves, finding out more. But the importance of it, it gives people confidence, it enables people to access services. And I think the other bit, apart from needing all that kind of technical information, is the kind of life experience stuff that goes around it. So certainly what I found, and this was 1999, I think I did mine, so it's a long time ago, things should have changed and it's looking like it hasn't. One of the key things was misinformation. So being told, women who identified as lesbians or who at that point had a female partner, going along for smear tests and being actively told by GPs, practice nurses, no, it's right, you don't need one. So things were said like, you're not having proper sex, so it's all right, you don't need it. Or, oh, we don't really know, but no, I don't think you need it. So it was really, really poor. And because I worked in health promotion, I knew that, as you were saying, that there's quite a bit of work done in terms of cancer screening and cancer prevention around trying to make sure that everybody accesses the support that's available. And here was a group that were doing what you want them to do and going along and trying to access, in this case, cervical screening, and being told, no, sorry, I don't need it. Or being, just awful examples of women going for smear tests, not having disclosed their sexuality. So for those of you that are like to say smear tests are nothing to worry about, but they are quite exposing. It's not, you know, you're not providing your arm for someone to look at. So you're there usually with your kind of legs apart, with somebody kind of putting the speculum in. And I had so many stories of women saying that, you know, the practice nurse is obviously being lovely and saying, oh, so have you got a boyfriend? Or, you know. And then they've come out and women said the practice nurse left the room and didn't come back in several instances. So they were just left thinking, I don't know where she's gone. Nurses left the room, came back with somebody else, sometimes a male colleague. They had some kind of idea of, oh God, they're a lesbian, I'm a woman, I need a kind of chaperone, and just kind of went out and got somebody. So quite, quite devastating really, both in terms of what you've said, like the long-term consequences. That, you know, the point of screening is it's hopefully life-saving. So not accessing services or accessing them and having really poor experiences, which kind of echoes for LGBT people generally, on top of the fact that young people are not given good sex education. Socially we kind of expect young people to have sex, but when they're older, but we're absolutely not going to tell them anything about it. You know, you've got to figure that out for yourself. And actually for me, that's a safeguarding issue and a health issue. If you don't know what parts of your body are called, if you don't know what they're supposed to look like, if you don't know how they're supposed to work, if you don't know what's appropriate in terms of other people touching you, then you are incredibly vulnerable. So I know lots of people worry about sex and relationships education. Like, this is people's basic right, and sexual health is part of your health. It's, you know, if you think of physical, emotional, spiritual, I always miss one out, sexual health, they're all kind of key aspects of your health. Lost my train of thought probably now, but yeah, and it was, so the final thing I'll say, I think you started with an interesting point about kind of how research might be done. And at the time I did it, there was almost no research. I didn't do it as an academic piece of research. I wasn't an academic then, I was a youth and community worker. But actually my research got cited a lot because there wasn't anything else. So I think I was one of the few bits of research that interviewed women. I did focus groups and interviews. One of my kind of colleagues in another bit of the country did her PhD on lesbian and bisexual women and cancer, and managed to did a different approach, did a huge questionnaire, but she managed to get replies, I think, from every single postcode in the country. So she wanted to kind of see what was going on across the country. But yeah, it was what the women in Bolton and Wigan were telling me in particular, that it was very much about isolation and not being able to come out, not wanting to go to their GP in case, you know, there might have been the friend who's a receptionist, or their friend, the receptionist's daughter goes to the same school as theirs. For working class women in particular, saying, well, what was I going to do, Jane? I knew I was a lesbian, but, you know, they weren't going off to university. They didn't have that kind of option of kind of going off and kind of reinventing themselves or exploring their identities away from kind of family or communities. So they got married, had kids. One of them said, that's why did Jane Thoitber, I realised when I was about 40 that it wasn't. So she said, I came out, so she had to start again. She'd bought a house and paid off a mortgage, so she had to get another house. Her husband didn't want to do a kind of supportive separation, and started smoking. So that was the other thing. So I was there as this health promotion worker, looking at particularly at sort of sexual health, but different aspects of health, but based in the health promotion team of a healthcare trust, who would at that point have been actively trying to get people to stop smoking. And here I'd got lesbians saying to me, I've started smoking, Jane. I never smoked, and now I've started because the only place I could go to meet other lesbians was the pub. And at that point you could smoke in the pub. So this is terrible. You know, we're telling women they don't need smear tests when they do, because as you said, the risk factors, there's lots of risk factors for cervical cancer. And also, you know, you might identify as a lesbian now, you might have a female partner now, but that might not have been the case, or you might have multiple partners, or you might in future have male partners. So yeah, so there's all sorts of issues. And what I particularly loved about today was how much trans information you provided, and kind of included non-binary identities. That wasn't part of what I did. We were way behind. Well, I was certainly way behind on that 20 odd years ago. So brilliant to see all that information. So yeah, that was kind of a bit about what happened with me.
Does anybody have any questions or anything they would like to add, or maybe ask Jane or one of us?
Sorry, I was gonna just go in. Thank you so much for sharing that, Jane. I wanted to, of course, I think you already answered this. It was about how you became passionate about the work that you do, but of course, definitely it's been answered already. But was there anything else that kept you motivated to keep researching in this field?
I think you're all doing different courses, aren't you? But certainly, yeah, I think anybody that goes on to work with people, whether that's in health or education or community settings, you know, I feel like equality information, so broadly I would talk about this as equality information, and understanding how oppression works and discrimination works, that's central, which is why I get upset, you know, when teachers get no support to deliver anything around equalities. That might be about racism, Islamophobia, homophobia, or stuff around sex education, because all your interactions with people are critical. And you know, so say for example for teachers, you know, you might be the only adult that a child sees outside their family, for example, or the only person that takes an interest in them if they come in from a particularly difficult family background. Your interactions with them are critical. So I think for healthcare workers, for teachers, for community workers, for anybody who's got any responsibility for working with the public, I'll tell you a story later. This awareness is so important. So I love this about the session that you talked about, raising awareness. So when I was doing that job, I had other little bits to my role, and one of them was training. And I went to train some practice nurses in a GP practice about young people's health, actually. And when we sat down to do the training session, we introduced ourselves, and my job title said I was a lesbian and bisexual women's health worker. So I said that was my title. And instantly the whole training session became about what are you talking about? Why are lesbian and bisexual women's health needs different? So actually, a lot of the discussion was around that, and I explained lots of the things that you've talked about and things that I was finding out. And one of the practice nurses said, she said, it's so weird, I get lots of gay men coming into my practice, but I never get any lesbians. And I said, oh, I bet you do, but maybe you don't realise. She said, no, definitely don't. And then we went back about 6 weeks later to do a follow-up session, and she said, oh, it's so weird. Ever since that session, I had loads of lesbians coming to see me. And I think, she said, I have done nothing different. I haven't said, and my feeling was, you won't be aware that you've done anything different because someone's talked to you about it, because you've thought about it, you're just more present with it. So, you know, I'm aware lots of my students have experienced Islamophobia as they're coming in, as they're travelling in on the buses and the trams. So now, you know, I make sure to ask people, we have a discussion about it. I might think at the beginning of a session when I'm teaching, if it's in the morning, I might kind of check in about how people's journeys have gone. There's something about being told something, even when you don't think you've done anything different. I think it makes you a bit more open. They might say something, or you might word something very slightly differently. So not saying, have you got a boyfriend, is so critical in any setting. So they might be a sex worker, they might have multiple partners, they might have same-sex partners, they might be trans. Using open questions or open statements and being very aware about what might put people off, so that people who experience discrimination and prejudice will watch. They're very used to knowing what kind of things might come up and how they might be reacted to. So they're often looking for clues to see how you're going to respond. So my kind of tactic is to always be really proactive, make it absolutely clear that you are not racist, you are not homophobic, and you've got to be proactive in that as a teacher or a health worker or whatever job you're in, because it's too scary for the person on the other end of that to have to find that out. You've got to be the person as the worker or the adult, you know, with children, it's the same as a parent. You've got to be the one to do the reassuring first.
Definitely, yeah.
So yeah.
Yeah, thank you so much for sharing that. Yeah, creating open conversations as well is just really important. So yeah, thank you so much for sharing.
Yeah, thank you. That's so interesting.